Good morning, everyone, and welcome to Health Service Management 402 Long-Term Care Administration. Hope everyone is having a wonderful Wednesday. Sorry to say that it is a rainy Wednesday, but we will get through that. We are going to be starting Chapter 3 today, the long-term care industry. I apologize for Monday. I had truly planned to be able to record a lecture at home, even though I was feeling a little under the weather, so that we would not get behind. However, I just could not get that done due to not feeling well. So we are going to get started today. I am better, not completely 100%, but we're going to get there. And I am excited to be able to be back today in the classroom and to be with you to talk about this very important necessity to our population, and that is our long-term care industry. The long-term care industry is comprised of private provider organizations that deliver services that can independently bill for the services in which they are providing. These organizations are both profit and nonprofit organizations and comprise of long-term care facilities and community-based service providers. There are some tax-supported government agencies included in this sector that provide social services. The long-term care industry also includes a support group of professionals such as, but not limited to, administrative personnel, paraprofessionals, caregivers, and ancillary personnel. In addition to some of the other vital supportive roles, the partners include the insurance industry, managed care organizations, and case management. And these are just to name a few of them. Yet, we're going to discuss the organizations and supportive roles of these two, of those who make up this critically necessary long-term care industry. And the first one we're going to discuss today is the private sector. When we hear the term provider, we most often think about the physician or the nurse practitioner or whoever it is that is delivering health care. But we need to really think about this and broaden our definition of provider, because it also includes any entity that gets reimbursed for services delivered. And the long-term care industry predominantly is funded by government, with Medicaid being the number one financer of long-term care. One also must keep in mind that certain sectors of the healthcare industry are more stringently regulated than others. Now, the private sector, as we said, are broke down. It can be community-based services, a quasi-institutional providers, which we will discuss, and institutional providers. And we're going to discuss all of those in detail. let's get started and start talking about and look at our community-based services. There are four main types of providers that make up and comprise the community-based providers. The first one we are going to talk about are home health providers. These long-term care providers support and are in alignment with the philosophy of maintaining people in the least restrictive environment possible. What does that mean? Ultimately, this means allowing them to remain in their home and bring the skilled nursing care and rehabilitation, which is delivered by licensed professionals such as RNs, your physical therapist, just to name a few, in addition to some of the paraprofessional and aides that have been, those services have been written and ordered by the physician. And they bring those services into the patient's home. We need to keep in mind that this benefits not only the patient by allowing them to stay in their home, improving outcomes. In addition, it is much more cost effective as opposed to being hospitalized or placed into a long-term care facility for the very same services. Medicare guidelines have evolved since 1988. And as a result of a class action lawsuit of Dunnigan versus Bowen, it resulted in an expansion of home health care services under Medicare. It removed the requirement of a 3-day hospitalization prior to being able to receive home health services at home, as well as it did away with the maximum 100 visits. The change in Medicare paved the way for growth of the home health agencies between 1990 and 1996 from 5,800 to 9,900. We need to keep in mind that Medicare focus is on clinical-oriented outcomes, such as skilled nursing care, of which this is the most common service provided by home health agencies. They do not support just long-term support and assistance. That is not Medicare's focus. That does not fall within Medicare's focus. Medicare's focus is clinically oriented based upon those skilled nursing care functions. Their focus is not the long-term support and assistance, as this is considered custodial care. It's considered custodial care. Medicare is the single largest payer for home health services. Let me reiterate. Medicaid is the number one and largest payer of long-term care services. Medicare is the single largest payer for home health services. You need to make sure that you have notes reflecting that, because that is critical to keep separated in your mind as to who pays what in that regard. Let me move. Homemakers. Homemakers and personal care service providers. Many private agencies offer services for in-home assistance and chores such as bathing, light housework, laundry, transportation back and forth. Medicare does not pay for these services. However, with some of the changes that have evolved in regard to Medicaid, some of this may be covered and reimbursed under Medicaid. As it has been determined through some government funding and grants that providing this type of assistance and services within the home to patients within their homes allows them to stay in the home longer, actually resulting in cost savings to the organization because it costs less to have a homemaker and personal care service provider go into a patient's home and provide those services as opposed to that patient going into a long-term care facility. Your adult daycares, these are community-based extramural services. They provide respite care for families. Remember, we talked about that the largest provider of long-term care goes unrecognized as providers for long-term care because it's usually patients' families and friends that are providing this care within a home setting, whether it be in the patient's home or within the person providing the care's home, and it becomes unrecognized, not acknowledged, and they are not reimbursed or paid for those services. But there are times that, my goodness, you just have to have a break. And that's how these adult daycare centers are able to provide some respite care. Now, these respite care services could come in the form of, bringing care into the home, allowing you, or bring your loved one into the adult daycare to provide care for them, much like a child's daycare, which allows you the opportunity to go to work and to do some of the other things that you need to do. Our adult daycares today are highly focused on the services being provided that bring awareness to prevention and health maintenance that would prevent or delay that loved one having to go into a long-term care institution. However, some of the adult daycares have become a little more clinical in nature, and some of them have become alternatives to the home health care and assisted living as a transitional step before they're placed in that home health. Now, those agencies or centers are going to be deemed for that specific purpose. And really what this does is it really helps to reduce some of the stress that is brought on by the change in the environment that the loved one is going to suffer from. And at that point in their age, and regardless of what the disease process is, this is critical. And you're going to see that as we move through this study, and when you get into the long-term care facility, if you've not had much exposure to that, then you're fully going to be able to, it's kind of like all the pieces of the puzzle are going to go together, and you're going to be able to see that picture very vividly. Any questions? Please note that if you do have questions, to please let me know. You can contact me via my contact information on the front page of your syllabus. So now let's talk about our hospice services that are available. Medicare added hospice benefits back in 1983. Unfortunately, this was 9 years after the first hospice opened in the United States. There are specific conditions of participation that must be followed in order to participate in this program. Under Medicare's conditions of participation, the physician needs to certify that patient's life expectancy is 6 months or less. Now, with that being said, if you ever have a loved one go on hospice care, I've worked for hospice, and I know that for families that's very difficult sometimes, because it's like giving them a time frame. And I just want to caution you that this time frame is based upon clinical practices and what has been the norm over a certain period of time that's been studied. There have been patients that we've had on hospice when I was working there that would be there 3 days up to a year and a half. And at that year and a half mark, I'm not saying that they passed away. It may have been that there was an improvement and we had to discharge them. And sometimes that does happen. But ultimately, the physician has to say, based upon what I'm viewing and the medical results that I'm looking at, based upon all of that criteria, it looks as though that this patient has 6 months or less. The patient also has to be willing to waive the right to medical treatment for that terminal illness. So let's say we have a cancer patient who has came on board and is now a hospice patient. This patient says, I am not going to take any more chemo, radiation. I'm not doing anything else to try to prevent the progression of this disease. You know, and most often it's to the point when this happens, the patient has already exhausted treatment options and nothing really seems to be working, or it has already reached its peak. But hospice care is palliative care, where the patient is being treated and kept comfortable as they are dealing with their disease process. Medicare benefits for this services, they're not limited to just 6 months. As I said before, we might have had a patient on service for a year and a half. But there has to be changes or reasons that will justify and warrant the patient's remaining on that service. If there has been improvement in that patient's medical status, then there is no choice but to discharge that patient from hospice services. If the patient's medical condition has remained the same, unchanged, or declined slightly, then there's got to be enough proper documentation to ensure that the conditions of participation are still being met in order to remain on the service. Medicare is the number one source of payment for hospice care. Now, there are some other service sources that are included. I mean, you can have a private insurance that will pay for part of it, and even Medicaid will reimburse some of that as well. And there's your. Now, a hospice care, I need to make sure that I cover this. Hospice care, most of that is provided within the patient's home or a family member's home in which the patient is residing. There are situations where hospice care is provided in what is known as an inpatient facility. This is considered a hospice house. We do have a Bowers Hospice House up in Lewisburg, I believe it is. And it is an inpatient facility because there are times that the patient doesn't want to pass at home, or the family may not be able to emotionally deal with the concept that their loved one passes at home. So at that point, they may feel more comfortable going into an inpatient facility where around the clock care and support is provided for their loved ones. The rooms are set up and designed to be a room just like home. You're still able to stay with your loved one during that process. We do need to be mindful that the hospice houses, these inpatient facilities, are built and ran through donations. There are a lot of the costs associated that has to be set aside through donations, and then you have your operational costs for your staff that will come as a result of the reimbursement from your source of payers. So that has to be broken down. Hospice programs have grown tremendously. And we've talked about most of the care being provided in private homes. We do also need to keep in mind that home health agencies can also have a hospice component in their service lineup that they provide. If your loved one is already in a long-term care institution or nursing home, as it says here on your slide, hospice care can be brought in and provided to them and their family and the family as well. This is a part of the service lineup that is provided through your long-term care institution. Your long-term care institution will have a contract for services through the hospice organization. There is also a provision here where you say, you can see that it says others are part of a hospital. And we've talked about the respite care. Where this comes into play is you may have a family who has been caring for their loved one for, several months, and they really need a break. They really need to take a vacation. They just need a mental break from it all. Or they may have another family crisis in another area that they need to go and attend to. Most of your hospice agencies have a contract with the area hospitals where a number of beds in a designated area of the hospital has been set aside to be used for hospice patients to be cared for in conjunction with and between hospital staff and hospice staff to provide respite care for the family for up to 3 to 4 days. Any questions? Okay. We'll move on, and we're going to talk about the quasi-institutional providers. These include a range of facilities that are often not with clear-cut distinctions. And they are classified into 3 broad categories. Independent living facilities, of which are not truly institutions because they don't deliver health care. Your custodial care providers, because their services are limited to social support and personal care. And then we have our assisted living facilities and nursing homes. However, the first 2 categories, your independent living and retirement centers and custodial care providers, are really what the 2 categories that are referred to as quasi-institutions, because the clinical, because they provide the clinical-oriented services that can either exist or be non-existent in the minimal of these facilities. Whenever you have, when we look at our independent living and retirement centers, they fall into 3 main types: government assisted housing, private pay housing, and co-housing. Now, these types of housing are going to differ from other institutional settings because staff are generally not present 24 hours. In these type of settings, usually you have your general manager, that has office hours maybe 5 days a week and can be on call. on the other times in your independent living and retirement centers. Because independent living is you are still living on your own, doing everything on your own. It's just if you need assistance or something is going on, you have someone to call and you have resources at your fingertips that you may not have otherwise if you were just in your own home, in a community where maybe you don't have any family nearby and friends to help you out. Your government-assisted housing falls under the United States Department of Housing and Urban Development, known as HUD, and it administers 3 different housing programs. These programs are for low-income people, including the elderly and disabilities. They also administer federal aid to local housing agencies in order for this to happen. Under Section 8 of this particular government housing or government assisted housing, this particular program will provide vouchers or certificates to individuals who have low income that allows them to apply that toward their rent. And these programs are managed by local housing public agencies. In Section 2002, the supportive housing, this is for the elderly and it is specifically meant for lower income elderly, 62 years and older. Now we need to call to attention that HUD provides some interest-free capital, advances to private and non-for-profit sponsors in an effort to develop or finance and develop the support of this type of housing. HUD also provides rent subsidies for these projects to help make them more affordable. There's been a similar program under Section 811 of the supportive housing for persons with disability. And if you ever think about, if you've seen the truck going around town that says Meals on Wheels, and we know that that is where meals are being taken into the home to individuals who have met a certain criteria to qualify for that. And this type of program is supported under Section 811 under the supportive housing and persons for housing. Let me start that over. Supportive housing for persons and disabilities. I'll get that out. And these type of services are arranged with home health agencies. Sometimes they have to have transportation from community to the provider and clinical services that need to be arranged with home health agencies. And this Section 811 helps to coordinate and help that to occur. Well, there's that PowerPoint. Sorry, guys. Private housing. This is our upscale retirement centers, and as an occupant of a private upscale retirement center, you are expected to pay an entrance fee, plus you pay a monthly maintenance or rental fee. A lot of times the evening meals and transportation and activities can be included in your monthly rental or maintenance fee, but it may also need to be paid over and beyond. A lot of that is going to vary from facility to facility. But a good example of this upscale retirement center is the Havens out on Route 20. These type of complexes have various types of recreational facilities and social programs. And I know that for a fact, not only from the Havens, but Glenwood Retirement Center has also incorporated a retirement housing area where you can live in your own private home. And you can go in and you can live just in the retirement area, but those are very limited. And they have people come in from the community, different organizations that, like on Sunday morning, you'll have various pastors and people from different churches who will come in and provide Sunday school, a worship service. You may have a special singing group come in. You have people come in that will maybe have game day. Sometimes your area providers of different services and resources will come in and do like a community fair. And with that, they're able to see some of the resources that are available to them in the community. In addition to, it's just a fun time because you have special food and you play games. It's just a wonderful day of socializing. I also know that when I taught Sunday school, I routinely had our students on Sunday mornings would make cards for our nursing home residents, and they didn't necessarily have to know that resident. They just would do a homemade card, and they didn't even have to sign their name. They just could put our church name on it. And we would mail those out, or someone would go and deliver them. And I remember one year we actually paid a visit to the nursing home or to the retirement center, because we actually did go to the Havens. And we handed out Easter baskets. We went and knocked on everyone's door and handed out Easter baskets and gave them a card. And that was just a wonderful experience, not only for the residents, but it was for my young students as well. Now, at times with these private pay housing, these upscale retirement centers, you will have to pay maybe extra fees for other services. And just some services that may be provided at an extra charge might be the cleaning, transportation, any kind of a basic assistance. Or your doctor visits may be included in your monthly rental, but the shopping trips to the mall or to Walmart, or maybe to go out to eat, anything like that may be an extra charge. Any type of nursing and rehabilitation service that may be required for you, may be needed, will be arranged through a home health agency to be delivered to you. Any questions? I have a couple of questions for you that need to be included in your homework assignment from today's lecture. Who is the largest payer source for long-term care? And who is the largest payer source for home health services? Let's move on and talk about our co-housing. Co-housing is a type of collaborative housing where residents actively participate in the design and operation of their own neighborhoods. This is a concept that has been developed based upon a design that's been used in Europe, and it's been most successful there. The main feature of housing communities include condo clusters across a central courtyard, a common house where residents can socialize and share meals, and a system where the residents operate and maintain the property themselves. I had a patient that came through outpatient pulmonary rehab, and she was doing remarkably well. She decided to sell her home here in the area, and she was moving, to a retirement community in Florida. And she was so excited because she was going to have a condo, and they had a common gathering place where they could gather and they could cook their meals and have a big meal together. They had social events in that big room. It was just like a gathering area. They had that commons area. And then they all got together and they maintained the property. Everybody had a job, and they divided it up to make sure that everything was maintained. And now that's one example. Now, my uncle, God love his heart, I have felt like he has lived the life for the last 10 to 15 years. But he worked very hard his whole life to be to this point. But he retired to Florida. He lives in Titusville, Florida, and he lives in a retirement center where, yes, they have a condo, they have a commons area, but he lives right on a golf course. And I remember talking with him one day and just asking him, I said, what does your day consist of? Because now he was an avid golf player and he's traveled all over the country playing golf. And he said, well, he said, I get up and I have breakfast, I have my coffee, and I go out and I play a few rounds of golf. And then he comes in and he eats lunch and he takes a nap and he goes out and he plays a few rounds of golf. And then he comes back in and he has dinner. And if they don't have some type of an event scheduled in the commons area, then he goes back out and plays a few more holes of golf before he comes in and retires for the evening. But, he has sent me pictures of Valentine's Day dances and sock hops and just different things that have gone on in that commons area as a part of the activities that have been designed and how this co-housing environment works. Any questions to this point? Okay. Let's talk about custodial care. Custodial care, we need to look at in that the facilities in this particular area go by various different names. They could be considered adult foster care, board and care homes, personal care centers. There's a whole host of different names that can fall into this particular facility grouping. Care is generally rendered in these facilities by paraprofessionals rather than licensed staff. Most of the time, these are homemakers, CNAs, and things of that nature. Funding, this is reimbursed through Medicaid, insurance, private insurances. We need to remember when we talked earlier in the lecture that Medicare's focus is not on custodial care. It is on skilled nursing care, not custodial. So Medicare does not reimburse for this. There is a much greater need for this type of providers under the provision of money follows the person program. Just wherever the person goes, that's where the money goes. It's been set aside for their care, whether it be into, they go into the long-term care facility and come out and go into a custodial care facility. Usually in these type of facilities, there's a skeleton staff that are employed to deliver the services that are needed. And I told you, as I said, most of the services provided are going to be paraprofessionals that are going to be your CNAs, your personal caregivers, that type of thing, people who could come in and cook meals and that type of thing. There are low reimbursement rates for this type of services. Therefore, we've really seen a decline, unfortunately, in the number of custodial care providers. I know at one time there were numerous custodial care providers in the area. However, some of those have closed because of decreased reimbursement and not being able to keep the doors open with the money that they were being paid for the services that they were provided. Now, we do need to keep in mind when we were talking about hospice services being delivered, in the various different settings, hospice services are delivered into your custodial care homes as well. I'm going to try to get through as much of this as I possibly can. We might run just a few minutes over. Okay. Institutional providers. These are the most visible sectors in our long-term care industry, as they generally connote some type of degree of confinement within that institution because of the high level of dependency, which just means that they're very dependent upon people to care for them. And this is an ideal situation for those individuals. These type of institutions include assisted living facilities, nursing homes, continuous care retirement centers, and we're going to talk about those a little bit just briefly. Our assisted living facilities, this is the fastest growing type of long-term care institution. And services range between custodial care and skilled nursing care. It can be scheduled and unscheduled assistance, and they provide basic nursing care. Assisted living facilities operate predominantly on a private pay basis, plus extras according to the level of nursing care needed. There may be an entrance fee that could be equivalent to 1 month's rent. Just like if you go out to rent some place, you have to generally pay a deposit, and usually that deposit is a month's rent. Overall cost is about half of skilled nursing facilities. Okay. In your assisted living facility, a basic month's rent generally covers rent, board, and utilities. And there can be additional fees that are charged for nursing and personal care services. Medicare, however, covers some of the home and community-based service, covers that community-based service waivers. Unfortunately, upscale facilities do not participate in public payment programs. Example, the Havens out on Route 20. That is private pay. They do not participate in any type of waivers, community grants, things of that nature. All states are going to require licensure of assisted living facilities, meaning there is regulatory oversight, and this is on the rise as many are beginning to provide services for dementia and Alzheimer's patients. When we talk about nursing homes and long-term care facilities, most people think of long-term care, that long-term care is synonymous with nursing home, which is a very common misconception. The nursing home has no real specific meaning, and in terms of literature in the healthcare realm, nursing home is generally used for facilities that are licensed as nursing homes and are often certified by federal government, meaning licensure of the nursing homes is mandatory in every state, and certification enables a nursing home to participate in Medicare and Medicaid. Any questions? Under the Medicare and Medicaid patients, they can receive skilled nursing facilities. They can go into subacute care facilities or an intermediate care facility for individuals who have intellectual disabilities. So let's look at the skilled nursing facilities first off. These skilled nursing facilities require nursing homes to be licensed. Certification, as I said, enables a nursing home to participate in Medicare and Medicaid. These facilities are going to provide a full range of clinical long-term care services, and a significant number of the patients have cognitive impairment, meaning dementia or Alzheimer's. The nursing home industry in the United States is dominated by private, for-profit nursing home chains that operate a group of nursing homes under one corporate ownership. And this is very true. The Westwood is operated under, I've forgotten the name of who they're operated under. Glenwood, I think, is under Sunrise Corporation, and Glenwood is, they're not owned by a large company, but they do have several facilities that is governed by a board of directors. Medicaid is the largest single payer source for nursing home services. I do encourage you to read through these different segments because I am truly hitting the highlights of how they are broken down, who pays, and what constitutes the type of patients that are in them. But these different areas give you some very specific details and examples of skilled nursing duties and services that will be provided that you need to be familiar with, because you could very, very easily see some of these things on your test. Subacute care centers or facilities. These patients are needing subacute care, and they may be recovering after a hospitalization, but still may be subject to some complications while they are trying to recover. And the patient needs a little bit more nursing intervention than what is included in a skilled nursing center. There are 3 main institutional locations that can provide such a thing, and that is a long-term care hospital, a hospital transitional care unit, or a freestanding nursing home. And all of this can vary in terms of availability, cost, and quality. I can give you an example. Years ago at Princeton, we had a long-term care unit, and this was specifically designed for the patient that really was not sick enough to be admitted to the hospital, but was not really well enough to return back to the long-term care facility that maybe they were in prior to their hospitalization. So this enabled us to be able to still care for them and to ensure that they had the intervention to keep them on that road to recovery, because we were able to monitor, treat any of the type of technical complex care that they may require. We talked about the different types of locations. Intermediate care for individuals with intellectual disabilities. This is a separate certification category. Most of these patients have additional physical disabilities, such as they may have seizures, type of behavior problems, mental illness, visual impairments, and they can have a combination of any of these conditions. These facilities have to provide active treatment that entails aggressive and consistent specialized programming that will include skill training to try to help enable the patient function as independently as possible. Any questions? The continuing care retirement communities, these are full service continuing care retirement communities, also called life care communities, where they integrate and coordinate independent living and other institution-based components of the long-term care continuum. Now, guys, I read that directly right out of the book because there's just no better way to describe that. And Glenwood Retirement Center is a classic example of a full-service continuum care retirement community, because they have the different levels of services on their campus. Their whole concept revolves around aging in place, and they provide services from housing, healthcare, social services, and health and wellness programs. And they really work to promote that level of independence by preserving and that independence by providing assistance and nursing care whenever it is needed by the resident. Now, we do need to be mindful that there are three main levels. There's independent living, custodial care, assisted living, and skilled nursing care. And for most of these, or for the most part, this type of continuing care retirement community requires some private financing. With the exception of the services that are delivered in a Medicare certified skilled nursing facility. And there are three types of contracts that are very common within this type of setting. The first one is a life care or extended contract that incorporates a package. It's a complete package of services that include everything on the campus. The second contract is a modified contract that provides for support services in the independent living, and it includes specific guidelines, of which you can take the time to read that because it is very self-explanatory. And the third level is a fee-for-service contract that can also include support services in the independent living. There's a wide variation in the entrance monthly fees based on the type of amenities and the type of contract that you are wanting. This type of living option is directed to the middle and upper middle class clientele. And these communities can be operated and are operated both for-profit and non-profit organizations. And the residents typically choose to enter communities when they're in their late 70s and are still relatively healthy and can enjoy still living independently and but yet having some assistance if necessary. Ladies and gentlemen, that is going to conclude our lecture today. We will pick up on Friday on page 56 under the insurance sector of the chapter, and hopefully we will be able to conclude this chapter on Friday. Hope everyone has a wonderful remainder of Wednesday or hump day, and I look forward to seeing you back on Friday.